Welcome to CleanMedKE, where we make clinical medicine and surgery clear, structured, and clinical. Today, we're diving into the complex world of the coagulation cascade and blood thinners. Before we begin, a brief medical disclaimer. This content is for educational purposes only and does not constitute medical advice. Think of hemostasis as a delicate scale. On one side, you have prothrombotic forces, like exposed collagen and tissue factor that want to plug leaks. And on the other, antithrombotic forces, like nitric oxide and protein C, that keep blood flowing. To understand how we intervene pharmacologically, we'll use the construction site metaphor. Phase 1 is laying the bricks, platelets. Phase 2 is pouring the mortar, coagulation. And phase 3 is the demolition crew, fibrinolysis. Let's look at the bricks. Primary hemostasis occurs in 3 steps. First is adhesion, where platelets bind to subendothelial collagen via von Willebrand factor. This leads to activation, where the platelet changes shape and releases signaling molecules like ADP and thromboxane A2. Finally, aggregation occurs as fibrinogen links platelets together through the GP2B3A receptor, forming the initial platelet plug. This is where our first class of drugs acts. Aspirin works early by inhibiting COX to prevent thromboxane production. P2Y12 inhibitors like Clopidogrel and PDE3 inhibitors like cilostazol target the activation phase. For high-risk scenarios, GP2B3A inhibitors like abciximab literally cut the connection between platelets to stop aggregation. A key clinical insight, these drugs prevent clot formation and propagation, but they do not break down existing clots. Now we need the mortar to stabilize those bricks. This is the coagulation cascade, divided into the intrinsic pathway, activated by collagen, and the extrinsic pathway, activated by tissue trauma. Both converge on factor X, the hero of the cascade. Factor X converts prothrombin into thrombin, which then turns soluble fibrinogen into a tough, cross-linked fibrin mesh. To stop the mortar from setting, we use anticoagulants. Heparins act as indirect inhibitors because they require antithrombin 3 to work, acting like a handcuff for clotting factors. Unfractionated heparin inhibits both factor Xa and thrombin equally, while low molecular weight heparin, like enoxaparin, is more selective for factor Xa. Fondaparinux is the most selective, only inhibiting factor Xa. We also have direct inhibitors. DOACs, like apixaban, hit factor X directly, strike zone 1, while drugs like dabigatran hit thrombin, strike zone 2. Then there is Warfarin, which takes a different approach by hitting the liver factory. It prevents the synthesis of functional factors 2, 7, 9, and 10 by inhibiting vitamin K epoxide reductase. Eventually, a clot needs to be removed by the demolition crew. Naturally, TPA converts plasminogen into plasmin, which shreds the fibrin mesh into D-dimers. Pharmacological thrombolytics, like alteplase, turbocharge this reaction. These are our clot busters, reserved for life-threatening emergencies, like an ischemic stroke within a 4.5-hour window, due to their very high bleeding risk. Why do we choose one drug over another? It depends on the flow. In high-flow arteries, clots are white and platelet-rich, so we use antiplatelets for conditions like MIs and strokes. In low-flow veins, blood stagnates, leading to red clots rich in fibrin and RBCs. This is why anticoagulants are the mainstay for DVT, PE, and atrial fibrillation. We must watch for pitfalls, specifically heparin-induced thrombocytopenia, HIT. This occurs when the immune system forms antibodies against the heparin PF4 complex, leading to massive, paradoxical platelet activation and widespread clots. If HIT is suspected, you must stop heparin immediately and transition the patient to a direct thrombin inhibitor like argatroban. Finally, if a patient on these meds starts to bleed, you need the antidote. Protamine neutralizes heparin. Vitamin K, or PCC, reverses warfarin. And andexanet alpha is the decoy receptor for factor Xa inhibitors. For dabigatran, we use the monoclonal antibody idarucimab, and for thrombolytics, we use tranexamic acid, TXA, to inhibit plasminogen activation. We hope this guide clarified the complex balance of hemostasis for you. If you found this structured clinical insight helpful, please like, share, and subscribe to CleanMedKE. Visit us at CleanMedKE.com and follow our socials for more clear, structured clinical content. Thanks for watching.